This is Martin Gutenberger. I will be talking about how to go through a anal fistula MRI. So to start out, I just have this diagram here that shows the different types of fistula. You have extra sphincteric fistula, which don't really arise from the anus, and they pass through or above the sphincter, and they just go into the ischial fat that way. You can have transsphincteric fistula, which go through the internal anal sphincter, and then they go through the external anal sphincter, either through it a long course or just traverse through it to the ischial fat. Or you can have intersphincteric fistula, which would go through the internal anal sphincter, but then stay within the fat plane between the internal and external sphincters, and then go into the medial gluteal fat. Or you can have submucosal fistula, which we don't typically see. So this is our Fistula Protocol MRI. It's very similar to rectal cancer protocol. The difference is that there is some diffusion imaging in there, and we do a little bit more post-contrast imaging. So to start out, the workhorses of this are going to be your high-resolution T2 images. In this patient, we have sagittal and axial images, and I will show you what a fistula looks like here. So this patient has a fairly simple fistula. So when you come down, this is the rectum, and as you come down here, you'll see this muscle wrap around the rectum. This is the puborectalis, and that's the beginning of the anal sphincter. On the coronal, it looks like just a thickening of the muscle here. So this is the levator ani muscle, and then this is the puborectalis. So the sphincter begins here. This is the internal anal sphincter. This is the fat plane between the internal and external anal sphincters, and this is the external anal sphincter. So you follow the sphincter down on the T2, and you begin to look for any sort of kind of bright tube passing, of T2 hyperintensity passing from the sphincter into the fat. So here is this person's anal fistula. It's here in the medial gluteal fat. So coming from inferior to superior, it passes in the medial gluteal fat, goes through the external anal sphincter right around here, and we generally describe the sphincter as a clock. So 12 o'clock would be here, 3 o'clock, 6 o'clock, 9 o'clock. So this is going through at around the 11 o'clock position, and then we lose it for a little bit, but it's probably right in this area going into the internal sphincter. Sometimes when you lose it on the T2, the T1 images will be helpful. You can see the fistula really here on the post-contrast T1 small field of view images really well. The fistula passes here anteriorly. You can see a little black dot in the middle. That's fluid within it, which means it's patent. And then you can see it pass here in the intersphincteric space and then into the internal anal sphincter. So this is a transsphincteric fistula. It does not have an associated abscess. That's something that's important to look for on the post-contrast images, and it arises from the anal canal at approximately the 11 o'clock or 12 o'clock position. I generally like to describe about how far from the anal verge it is, so I will use my sagittal images and coronal images to try to find where it is. So it probably should be in this area somewhere. So I would measure that as a few centimeters from the anal verge. And then I would describe the course of it, approximately how long it is, and what it traverses, and if there are any associated abscesses. The other sequences that are done with this are really for problem solving. So the T2 fat sat can sometimes be helpful, just generally looking for edema. It's also a large field of view image, so any sort of large abscess that might go into the pelvis you would get, and I also use it looking for lymphadenopathy or anything like that. And then your large field of view post-contrasts also can be helpful, especially because they have coronal and sagittal reconstructions. And so having these pulled down, you can see again, here's this fistula. You don't see it as well as on the small field of view image, but if you have a large abscess, again, you would probably see it better on these. and these are also good for looking for lymphadenopathy or any sort of inflammation or bowel wall thickening that might be around, especially if the patient has inflammatory bowel disease. I have an accessory case here just to show you another fistula. This one you can see a lot better. So following the rectum down, somewhere in here is the puba rectalis, so we're getting into the anal musculature. Here we see this nice, bright T2 tubular structure passing through the internal anal sphincter at about the 6 or 7 o'clock position, passes directly through the external anal sphincter, and then passes along into the medial gluteal fat. This person also has some low T2 signal over here that it's not really that nice tubular fluid signal thing like the other one was. So this is actually an old scarred fistula here that looks like it used to pass kind of more anteriorly on the left of the anal sphincter. So this one you can also see on the T2 post-contrast. You can see it pretty well. You can see there's some non-enhancing soft tissue in the middle, so there's a little bit of fluid or pus in there, and that also kind of convinces you that it's still a patent fistula. And this one doesn't have anything like that, so this is a chronic fistula on the left. This final case here is just to show you a more complex fistula. So this patient has some ascites. As you follow the rectum down, there's a larger fluid collection here. You can see it's enhancing around there. There's some kind of non-enhancing stuff in the middle. That's just complex. So this is a abscess here surrounding the lower rectum and the anus, and here you can see the tracts that communicate through the internal anal sphincter. There's one tract at about 10 o'clock and another one at about 2 o'clock. Both of those then communicate here to this abscess, which is anterior to the rectum. And then there's a fistulous tract that passes supra-sphincteric through the levator and then through the posterior gluteal musculature, and then passes into the gluteal fat. So those are the basics of what anal fistula and abscesses look like and what you're looking for. Generally, you're just going to be explaining where they arise from the internal anal sphincter, whether or not they pass through the external anal sphincter and where, and whether there are any associated abscesses.